Program now. So, respected chairperson, Dr. Anand sir, the Section Sadhana Memorial Psychiatric Hospital and De-Addiction Center, Sri Ganganagar, Rajasthan. Today's speaker, Professor Dr. Anand, from Department of Psychiatry, PSG Medical College, Coimbatore. And today, moderator, Dr. Aswad Babu, Dr. Rajalakshmi, consultant psychiatrist of Sneha Mind Care Hospital, Tirunelveli. My dear postgraduates, practicing psychiatrists, and their colleagues, good morning to all of you. I extend my warm welcome to all of you. Indeed, it's a great privilege for me to organize this All India PG webinar. And we have been conducting this monthly Evolve webinar almost for the past 2 years, and every fourth Sunday. There is a overwhelming response and support for this webinar among the postgraduates as well as the practicing psychiatrists across India. We are choosing the topic that is more relevant to the postgraduates as well as for the practicing psychiatrists. The speaker for this webinar is also a well-known person, an eminent personality, and the chairperson for this webinar also the senior psychiatrist from across India. The webinar is not only beneficial for the postgraduates, but also it is refreshing for the practicing psychiatrist. I'm thankful to Dr. Roop Sidana sir, a senior psychiatrist from Rajasthan, and Dr. Anand from Coimbatore for accepting our invitation and join this program in spite of their busy schedule on this Sunday. And today's speaker is Dr. Anand, a very close friend of mine, and we both are classmates at NIMHANS, and he is a professor of psychiatry at PSG Medical College, Coimbatore. And he is an eminent postgraduate teacher. He has been teaching for more than 20 years experience. He was an examiner for all the university across India, including as an examiner for NIMHANS. And Dr. Anand will speak about the evaluation and management of borderline personality disorder. Hope this topic will definitely useful for the postgraduates and as well as for the practicing psychiatrist. The speaker will ask 5 questions during the presentations. The first and quick responder will receive attractive prizes, and all the participants, especially postgraduates, enter your correct answer in the chat box. The postgraduates who won the last quiz will be announced by our moderator, Dr. Aswad Babu. Now I hand over the session to Dr. Aswad Babu and Dr. Rajeshwari, psychiatrist of our Sneha Mind Care Hospital. It's over to you, Dr. Aswad.
Thank you, sir. Thank you so much for the introduction, sir. Thank you for the opportunity. Warm greetings to everyone joining us today for the Evolve Psychiatry lecture series. I'm happy to welcome you all, the participants from across the nation, who have made this program a grand success till date. Very good morning to all the respected seniors and the juniors present here. Myself, Dr. Ashwath Babu, currently working as consultant psychiatrist at Sneha Mind Care Hospital, Tirunelveli. I'll be moderating today's session along with Dr. Rajalakshmi. First and foremost, I would like to express my sincere gratitude to our course director, Dr. C. Paniselvan sir, whose vision and leadership have made this lecture series possible. Before moving on to the session proper, I would like to introduce winners from the previous session. The winners list is like Dr. Saptar Shri SR from AIMS Diogar, Dr. Bhagya Shri from Tirunelveli Medical College, currently working at Snega Hospital, Dr. Pranjal Tripathi, Andhra Medical College, Dr. SR Nirmal sir from Dhanalakshmi Srinivasan Medical College, Perambalur, Dr. Sadhana from KAPV Medical College, Trichy, Dr. Kavipriya Gajendran from Madurai Medical College, Dr. Jayashri from Trichy Government Medical College. The list includes not only just postgraduates, we have faculties also from various eminent institutes. This shows that the reach of the program. Thank you all the participants. Congrats to the winners. Likewise, we'll be having quiz today also. The speaker for the day, Dr. Anand sir, will be asking 5 questions in between the session. The participants are specifically instructed to type their responses in the chat box only. First 2 members giving the correct answers will be selected as winners for each question. The winners will be announced in the next session. On that note, I move on to introduce our esteemed chairperson for the day, Dr. Roop Sidana. Sir currently is Clinical Director of Section Sidana Memorial Psychiatric Hospital and De-Addiction Center, Prerna De-Addiction and Rehabilitation Center in Sri Ganganagar, Rajasthan. Sir has did his MD in Psychiatry from the prestigious PG IMR, Chandigarh in the year 1982. Sir is currently the President of Indian Association of Private Psychiatry, Rajasthan branch. He is the North Zone representative to IPS. Sir has held various positions in the state, national, and the zonal level in the past, including past president of IPS Rajasthan State, past president of IPS North Zone, member National Advisory Board to IAPP. Sir has received awards like Dr. Gehlot Award, Kota Award, Dr. Shiv Gautam Oration Award. His area of interest being substance abuse, RTMS, and psychosexual problems. Sir, we are truly honored to have you with us today. Now, I humbly request you to introduce the topic for the day, sir. Over to you, Dr. Roop Sudhana, sir.
Am I audible?
Yes, sir, you are audible, sir.
Thanks to Dr. C. Paneer Selvan for inviting me to chair this important session. And as I understand, this is a very important series of program for postgraduate students all over the country. And the topic that has been chosen is very relevant and important because being a practitioner for the last 40 years, I find the borderline personality disorder is still poorly understood by the practitioners and by the postgraduates as well. It is a difficult area and a diagnosis which is made very late in the process of the illness, and it has a lot of implications because many of the patients with borderline personality disorder present in the emergency room with deliberate self-harm injuries. They are more prone to going into addiction. They are more prone to being misdiagnosed and treated in various categories like bipolar disorder, by schizophrenia, or transient psychotic episodes, because unless you follow the patient longitudinally for quite some time and spend some time with the patient and the family, you are not able to make a diagnosis. So, and as far as the management is concerned, it's equally difficult in practice. And you need to have a lot of special training to manage persons with borderline personality disorder. Otherwise, for a practitioner, it is very time consuming, very confusing, and gives you a lot of guilt, or puts you into dilemma what to do, what not to do. And because many a times patients with borderline personality disorder who are under your treatment, they do such they get into such problems that you feel that you have not been able to diagnose or manage them properly. And the dialectical behavior therapy, which is being practiced and is the treatment, is not available in our country, unfortunately. In the two cities, only in metropolitans or bigger institutes you get people. But still, I'm sure the speaker would highlight the important points for practice and in diagnosing borderline personality disorder and managing the issues which crop up during the treatment period. So over to the moderator and to the speakers. Thank you.
Thank you, sir. Thank you so much for setting the stage, sir. Now moving on to speaker introduction. With the introduction about the topic, we have the speaker for the day, Dr. Anand, sir. Sir is currently working as professor at the PSG Institute of Medical Sciences and Research, Coimbatore. Sir has done his MBBS from Coimbatore Medical College in the year 1992. Sir did his DPM and also MD from the prestigious NIMHANS, Bangalore. Sir has worked as senior resident at NIMHANS. Sir has worked as consultant psychiatrist at Lothrop Regional Hospital, Victoria, Australia for 5 years. He has received Bhagwat Award for a young psychiatrist at ANSIPS 2001. His area of interest being UG and PG psychiatry teaching and awareness on mental health. Sir is the right person to deliver the lecture on the topic. Sir, we are very honored and proud to have you in our session today, sir. Over to you, Dr. Anand, sir. The dais is yours.
Good morning, everyone. Am I audible?
Yes.
Yes, sir.
Yes, Anand, you are on.
Yeah.
You're on.
So before I start my topic, I would like to thank Dr. Paneer Selvam and the organizers for giving me this opportunity and slides. As rightly pointed out by the chairperson, we are going to have a discussion on a topic which is fairly difficult in terms of diagnosis as well as management for any psychiatrist in any psychiatry setup. So it poses a lot of challenges in terms of from the diagnosis point of view, and then like how we really manage. So I thought like I would give an overview about the certain clinical aspects. I'm not really going in detail about the theories behind borderline personality organization and all that, but mostly concentrating on the clinical assessment and then clinical management. So to begin with, we know that the term borderline personality was first proposed by Stern in 1938 to describe a group of patients. So it's very interesting to know that like why this borderline came. So it basically like, okay, they are neither fit into psychotic or fit into a neurotic or a psychoneurotic group. So they are bordered between these two. So that's why, that's how this came up. So the borderline personality organization was introduced by Kernberg, and he basically tried to refer to a pattern of behavior which is basically characterized by instability and disturbed psychological self-organization. So that's how the borderline personality organization was introduced. But we know that like, okay, the person Gunderson, who did a lot of work on this area, and then like, okay, he gave the characteristics of this personality. And even today in both ICD as well as DSM and whatever criteria that like we are talking about, all proposed by him. So it is basically like, okay, it's a very, it's kind of like it's a contested diagnosis for various reasons, because the phenotype of this is quite heterogeneous, like various presentations and then like various kind of disturbances that like it causes. And very interestingly, also very clinically challenging is that like there is an extensive symptom overlap with other psychiatric diagnoses. So there can be comorbidities, or the presentations can be similar to some other psychiatric diagnosis. So it's extremely challenging from a clinical point of view. And we also have a lot of debate on the validity of this borderline personality diagnosis. And we know that like among the personality disorders, the borderline personality disorder is the most widely researched, and it also kind of like has come out with lots of treatment guidelines and evidence base. So when we kind of like, okay, look at the classification, and a lot of debate and dissatisfaction exists on the classification system of personality disorder, because we know that like, okay, in the previously like, okay, we were kind of like using what we call it as a categorical kind of approach, where a symptom is considered to be present or not, yes or no answers. But that has been slowly kind of like, okay, moved to another concept called a dimensional conceptualization. Here, it is something like a personality trait can be present in a milder form for an individual, but when it becomes pathological and then like when it becomes a diagnostic entity. So that's a kind of approach that like we are moving towards now. Like, okay, so the borderline personality disorder, it's a kind of like borders on a wide range of conditions, and it also causes significant risks to explain various symptoms as well as problematic behaviors. If you really look at DSM-5, what we call it as a hybrid model, and it proposes the essential criteria. See, there is a basic criteria for any kind of personality disorder. So such as impairment in personality functioning and presence of pathological personality traits. So basically, we need to have this to call it as a personality disorder. In that, the DSM comes with six different personality disorders, including the borderline type. And DSM-5 describes this main features as instability in interpersonal relationships, self-image, and affect. and also marked impulsivity and self-injurious behavior. Now we are kind of like, okay, even though we are still following the ICD-10, but ICD-11 has kind of like has come out, and then like, okay, a lot of discussion is being happening in the academic point of view, like the differences between ICD-10 and 11. So ICD-10 DSM kind of like the equivalent of DSM-5 for ICD-10 is what we call it as an EUPD, like emotionally unstable personality disorder. And it has two types like impulsive and borderline subtypes. ICD-11 kind of like looks at the classification of personality disorder in a slightly different manner. That means the dimensional point of view, and it's kind of like trying to replace the categorical description. And here, the focus is on the evaluation of global impairment of personality functioning, classified according to the degree of severity. So it's something like somebody can have a personality difficulty. So you may not be qualifying for a full-blown disorder. When someone qualifies for a disorder, and then they can have a mild, moderate to severe kind of varieties. And this characteristics of BPD can be found. See, the ICD-11 comes out with, there are what we call it as a personality domain traits. So the borderline personality basically has negative affectivity, disinhibition, and dissociality. And just for completion's sake, that I'm telling that like the detachment and anancassia are the other dominant domain traits. Then a lot of debate and then a lot of discussions went on, and then the option of applying a borderline pattern descriptor was introduced later, which is similar to what we call it as a EUPD of ICD-10. If you really look at, this is a summary of what kind of symptoms the people with borderline personality disorder can present with. So not necessarily all can have everything, but these are all the areas, the domains. So we have emotional domains where the person are kind of like, okay, basically having a heightened emotional sensitivity, and they have a very poor control or poor regulation of their emotions. And they are kind of like considered to be having a slow return to baseline from emotionally heightened state. And the characteristic feature, what we call in borderline personality, is this chronic feelings of emptiness, which is also considered to be emotional domain, and difficulty in controlling the angry feelings. So these all come under emotional domain. And we have that interpersonal domain, where the consistent fear or constant fear of being kind of like, okay, the abandonment fear. So the person would leave me and go. So this kind of like, okay, constantly bothers persons with this borderline personality, which results in lot of this relational instability. And we also have this classic phenomena called splitting, where kind of like, okay, the person with borderline personality views people as what we call it as all good or all bad. Then we move on to this behavioral domain, which is kind of like, okay, manifested in lots of behavioral disturbances, which is usually picked up by the family members. And then this is how that like we get most of the histories. So the characteristic impulsive behaviors such as reckless spending, binge eating, and a lot of substance related issues, and recurrent self-harming behaviors, and also suicidal behaviors. And interestingly, this is where this kind of like the psychotic, the neurotic kind of like, okay, differentiation of this comes, what we call it as a cognitive disturbances. So the identity disturbances, so that they'll have a sense of a kind of like, okay, confusion about their own identity, including their sexual orientation and other things. And then like, okay, the borderline personality people are known to have or known to experience psychotic symptoms, which are transient in nature. What we also call it as a quasi-psychotic episodes. So when we kind of like, when they present in this kind of condition, a lot of time that like they receive a diagnosis of psychosis, but which is very transient in nature, and then like, okay, gets better with various interventions. We will discuss that later. And also, they are very, very prone to develop a lot of dissociative experiences, especially depersonalization and derealization kind of experiences. Just a small break. I think this is quiz number 1. See, the quiz, the answers are there in the presentation, either directly or indirectly. I kind of like, okay, I encourage all the postgraduates to make an attempt to give an answer for that. So this is the first quiz. Which cognitive bias is most commonly seen in borderline personality disorder? Overgeneralization, dichotomous thinking, catastrophization, magical thinking. So I'll just give about 10 seconds for postgraduates to go through this and then give your answer. I'll give my answer after a few more slides of my presentation. Okay, I'll move on to the presentation. Okay, so apart from that, the various domains of presentation, okay, there are certain things which requires some kind of elaboration. Aggression is very, very common, and many times this externalized aggression can result in a lot of intimate partner violence and various types of aggressive criminal behavior also. And offenders with personality disorder have 2 to 3 times higher odds of being repeat offenders. So that's a very important point to note. Then what we have is that okay, a lot of the sexually inappropriate or a sexually high risk behavior, the persons with borderline personality are known to indulge in, and they have a lot of comorbid substance misuse. They have higher rates of high risk sexual behaviors. They are very prone for sexually transmitted diseases and also prone for indulging in commercial sexual work. And women with borderline personality disorders are at increased risk of teenage and unwanted pregnancies compared with women with other axis 1 disorders. So these are all kind of like a summary of various studies which are done across the world. And it's also very important to note that women with borderline personality are more likely to be raped by a stranger and be coerced to have sex than women without a borderline personality traits. What is very, very important is kind of okay, it's in terms of assessment, also in terms of management, is the significant functional impairment this borderline personality disorder people have, particularly impulsivity and affective instability. And it prospectively predict negative academic achievement. Say they find it extremely difficult to kind of okay, persist with their academic commitments, and then able to complete their degrees, and then subsequently finding a job, and then sticking to a job. So it all becomes very challenging for these individuals. So in clinical populations, they experience greater impairment in work, social relationships, and also their leisure activities are very, very poor compared with people with depression. It's a very common, okay, it's kind of not only with depression, okay, if you compare with any individuals, the people with the borderline personality have a significant impairment in their general functioning. This is very important. We all know that okay, we make a diagnosis based on this, many times, the self-harm risk. So usually okay, this is considered as a repetitive in nature, and it is kind of okay, found out that the self-harm behaviors, recurrent self-harm behaviors are generally considered more common in females than males. And it takes variety of forms, it can be in anything, okay, cutting, bruising, burning, biting, and head banging. And the severity ranges from individual to individuals. You would have definitely seen patients who are kind of okay, indulging in very, very severe form of self-harming behavior. And these people report more frequent and severe and diverse methods of self-injury, and they have greater diagnostic comorbidities, something when people have got a recurrent self-harming behavior, a lot of time that you invariably find some other comorbidities existing along with their personality issues, and they also are likely to report more depressive symptoms. Suicide also is very, very kind of like, okay, very commonly associated, and it's very common. Around 60 to 70% of people attempting suicide at some point in time, and usually the rates of completed suicide is around 10%. Here there is a distinction between what we call it as a suicide attempt as well as self-harming behavior. So suicide attempt is motivated by a wish to die, but self-harm, especially in borderline personality, is usually conceptualized as it's more like a coping strategy. It's a kind of like unhealthy coping strategy, we can call it. So it is mostly to kind of like, okay, to communicate some kind of emotional distress. So that's how that like we understand their self-harming behavior. So they are trying to convey something, and this is kind of like, okay, so usually the suicide attempts are associated with the major depressive disorders, comorbid substance use disorders, the people who have a severe kind of affective instability, and obviously like people with a lot of hopelessness. Now I'll come to this quiz number 1. Answer for that, which cognitive bias is most commonly seen in BPD? I think most of you would have probably guessed it. It's the dichotomous thinking, all good or all bad. It's called that splitting. So that's an answer. I'll just move on to quiz number 2. So which of the following is true about self-harm or suicidality in borderline personality? I think if you really look at the answers are quite easy. Suicide risk is lower in comorbid depressive disorder. Self-harm is usually a suicidal gesture. Lifetime suicide risk in borderline personality is around 10%. Suicide attempts are more common in older individuals. So I'll give you about 10 to 15 seconds to have a look at this, and I'll give you the answers a bit later. Okay, I'll move on to the topic further. Okay, there are various assessment tools. Like, okay, so if you really want to kind of like, okay, objectively assess the personality, or if you are really looking at doing any kind of research with persons with borderline personality disorders, there are various assessment tools for the personality disorders. And then we are also aware that there are plenty of assessment tools to assess just the personality. So lot of things are kind of like, okay, the reliability and validity has been established. The SCIP-2 is a clinician administered interview for the assessment of PD according to the DSM. And they have an optional screening questionnaire. And so everything is linked to each personality disorder. And there is a diagnostic interview for DSM-4 personality disorder. And you have an IPD, that International Personality Disorder Examination, and Personality Disorder Interview 4. This is not a complete list. I thought I'll just highlight a couple of important ones. These are all common to all personality disorders. But there are a few kind of like, okay, the assessments are available for exclusively for borderline personality disorder. One is called Zanarini rating scale for borderline personality disorder. It's a clinician administered rating scale, and it's designed to measure changes in borderline symptomatology over time. So if you are really looking at assessing their progress or the long-term outcome on a long-term basis, like, okay, this scale may be used. And there are 9 symptom items based on each of the DSM-4 criteria, and they are basically grouped under 4 sectors. There are 3 affective symptoms, there are 2 cognitive symptoms, there are 2 impulsive symptoms, and then there are interpersonal dimensions. And so it's a kind of like the 4 sector scores sum up to provide a total score of borderline psychopathology. So it gives an overall picture, and then like you try to have a baseline assessment, and then like follow them over a period of time, and you look at the progress over a period of time. The comorbidities. See, this is a major issue. See, borderline personality disorder presents with these conditions as part of the symptom, or it can be comorbid condition. So that is where the clinical challenge really comes. So it's an heterogeneous condition. The symptoms overlap with depressive, psychotic, and bipolar disorders. sometimes like, okay, you come across most of the axis 1 diagnosis in these individuals. You will be thinking of one or the other psychiatric diagnosis for this. So how much it is part of the borderline personality and how much is kind of like an independent comorbid diagnosis. So that's where the clinician's real challenge comes. So it's important to discriminate between borderline personality disorder and disorders with shared symptoms and to recognize the presence of comorbidity. That's what really matter. That's what is really important aspect that we need to keep it in mind. So depression is very common, very frequently co-occur, and recurrence rates of depression are high in this population. And it is kind of like, okay, usually the depression is experienced as subjectively more severe compared to depression without this personality. And it is mostly related to interpersonal sensitivity. And it is considered to be more resistant and more persistent. So if somebody with depression with borderline personality or depression alone, the definite long-term outcome differs. And so they basically have a reciprocal negative effects. So one gives rise to one makes the other condition worse. This is a real challenge, I would say, a bipolar affective disorder, especially if you are really looking at soft bipolar spectrum, what we call it as a bipolar 2 and other subtypes. So that can really give a lot of clinical confusion in terms of what is what, whether it is a comorbid condition or whether it is a part of a borderline personality presentation. So there are a lot of similarities between these two, and it's a real clinical challenge. So the clinical studies suggest that people with borderline personality, they are at risk of being misdiagnosed. So it's very, very common, like what we see. And if you really look at the clinician's attitude towards this and then like trying to treat that, we could see that like there is a lot of difficulties happens in this area. And usually the comorbid condition with bipolar disorder has more severe presentation. And borderline personality is very highly predictive of future diagnosis of bipolar disorder. And it also kind of like increases the suicide risk phenomenally. Affective instability, which is the core feature of borderline personality. So this is really kind of like what we call it as a transient changes in mood in response to interpersonal stressors. The people generally describe it as a mood swings. And so this is very characteristic of borderline personality disorder compared to a sustained mood shifts in bipolar disorder. So we are talking about a pervasive nature of mood change in bipolar, but in borderline personality, it is usually transient in nature, and then usually it is in response to some kind of interpersonal sensitivity, stressors. And if we really look at the mood change in borderline personality is usually from euthymia to anger. But in bipolar, like we are talking about depression to mania. This is another area which is worth mentioning here. Okay, so the ICD-11 has come up with a new concept called complex PTSD, post-traumatic stress disorder. So it's something like someone has been exposed to a severe and interpersonal trauma, which is a long-standing, something like childhood sexual abuse or torture or slavery, which is an ongoing issue. So they call it as a kind of like a complex PTSD. And so we'll have to keep it in mind, like this is neither a replacement diagnosis of borderline personality or it's not a subtype of borderline personality. So the complex PTSD captures the developmental effects of exposure to complex trauma, as I mentioned, and they develop core PTSD symptoms, and they are usually enduring and pervasive. So it kind of like, okay, it also gives an appearance that like, okay, it's been there for a long period of time, and then like it gives an impression that like whether they have a personality disorder. So this is a new concept like which has been proposed in ICD-11. So when we are dealing with borderline personality, it's better to, because we are also dealing with a lot of trauma and then childhood sexual abuse and the effects of all that, which is a major precursor of a later development of borderline personality. So we need to really keep that in mind. So we also know that like the borderline personality is strongly associated with anxiety disorders, increased rates of panic disorder, agoraphobia, social phobia, simple phobia, and obsessive compulsive disorder. And we also know that like the substance use is very, very common, and it's almost touching around 80%. And if they have a comorbid substance use, you can definitely expect the impulsivity is more, and they are less clinically stable, because the substance use obviously complicates an already a complex kind of personality issues. And we know that like, okay, the eating disorders also is very common compared to a normal person. And the personality, like the eating disorders in women is around 17%, and then in around 3% of men, it can be there. And a high proportion of women also kind of like having a diagnosis of bulimia nervosa or eating disorder, unspecified kind of eating disorder, because this is one of the common symptomatology that like we get when we are kind of like eliciting the history from borderline personality. And on clarification, they also start reporting that like poor control over their eating pattern, and then like, okay, having a binge eating, and then like followed by excessive concern about their weight gain, and then like induced vomiting, and then compensatory behaviors, and those kind of things. And then the dissociative symptoms, especially chronic non-remitting dissociative symptoms and very complex forms of dissociative symptoms are very common. And usually the cluster B personality, not only the borderline personality, the histrionic and antisocial personalities are more likely to present with the non-epileptic seizures or dissociative seizures. And the other complex area to deal is this attention deficit hyperactivity disorder. So the overlap between bipolar, borderline, and ADHD is very high. And the ADHD and borderline personality share features of impulsivity and difficulty in controlling anger and aggression. And obviously, like if ADHD is present, and the impulsivity may be further increased. Okay, I'll come back to this quiz number 2 answer. Which of the following is true about self-harm suicidality in borderline personality? I'm sure most of you would have guessed. The right answer among the 4 responses is lifetime suicide risk in borderline personality is around 10%. So this is quiz number 3. Which of the following best differentiates borderline personality disorder from bipolar disorder? Best differentiates. Bipolar disorder lacks impulsivity. Borderline personality mood shifts are short-lived and reactive to stress. Borderline personality disorder is characterized by grandiosity. Bipolar disorder has a stable sense of self. So which is the best answer which differentiates borderline personality from bipolar disorder? I'll wait for a few seconds. Okay. So psychiatric management, we'll just move on to that. So there are some broad guidelines. See, there are plenty of guidelines available, like, and there are some broad criteria or broad guidelines that like I would like to really highlight about management of borderline personality. So to begin with, how we really use the psychiatry diagnostics, like, okay, how are we really going to make this, whatever criteria that we are using to make this diagnosis, and involvement of the management of individual cases. So we need to really see the individual kind of like as a whole, and then like what kind of comorbidities that like they have, and what kind of intervention strategies are suitable for them. And it's very important to keep it in mind that like what kind of targets or intervention, what is our target in terms of dealing with these individuals. A genuinely disciplined and evidence-based use of pharmacological treatment is very, very important. I'll definitely come back to that later. And working knowledge of risk management, because this is very, very important. When we are dealing with borderline personality disorder, we are dealing mostly with risk management. So the very, very important thing is that, like, okay, take as much as possible information and then like try to have a clear and current diagnosis of borderline personality disorder. So you need to really be clear with yourself about is the patient actually has borderline personality disorder? Is it a core symptomatology, or you are having a differential diagnosis? The other thing is that, like, whether the patient still has borderline personality disorder, like, okay, at some point, what time that like you are assessing, because borderline personality disorder can have a lot of fluctuations. And then like I have a couple of slides on the outcome, which I will discuss a bit later. Especially if you are really look at the borderline personality symptom stability over a period of time. So the personality psychopathology improves over time at unexpectedly significant rates. This is a good thing. This is a good point for all of us, because we can actually expect a better outcome with these individuals. So rather than having an extremely pessimistic attitude when you're seeing them for the first time, but they can show some kind of changes in their core psychopathology. And residual effects often persist in the form of sustained functional impairment. So very, very important to really look at their functional outcome and continuing behavioral problems and what kind of quality of life that like they have. So we need to really keep all that in mind when we are really trying to have a management plan for them. So it is always better to really explain the diagnosis in terms of medical disorder. So we can probably talk to them that like, okay, this is part of their personality. Probably they have a couple of pathological traits. And it is also useful to really kind of like, okay, talk to them from their personal point of view, their personal life. So when we are trying to say that like, okay, this disorder, and then it has got a lot of this contributing factors from your own personal life. So this is usually perceived kind of like it's kind of like, okay, so they also feel that like some amount of relief is given by these explanations to the patient. The most common problem happens, especially from a clinician point of view, is this invalidating attitudes about the borderline personality from the professionals. And this is very, very well documented. So many times people, we have a lot of doubts about do you really call this personality disorder as a mental illness or not? So it's something like this aspect of you are actually bad, not a mad person. So this is kind of an invalidating attitude. So this can have a lot of negative impact on the patient. So when you are presenting a clear diagnosis, and then that gives a lot of relief to the patient. It's important to have an open information-based dialogue, especially during the early contacts. So the clear understanding of themselves and helping them to make sense of their difficulties. So we'll have to really help them to identify what kind of difficulties that like they are facing, and how they can be able to connect with other people and becoming a part of their collective owned identity. Probably one of the most important part from a clinical point of view, because a lot of time, like, okay, when you are dealing with borderline personality disorder, the prescriptions are not really going to help in a very, very great manner. I think this message has to be really conveyed to all of us. And polypharmacy is very, very widespread because they present with various symptoms. Their presentation changes from time to time. So as a clinician, we are kind of like under pressure to use some kind of medication. So we'll have to have some kind of clarity about what are we going to do from a pharmacological point of view. So a lot of pressure for us to focus on medical treatment. And we also have a lot of psychiatric medication options are coming up. Okay, you can use this drug, you can use that drug, and this is safe and that is not safe. So many options are coming up. So we are under pressure. And we are also kind of like, okay, looking at push for remission. So there is something called response or a beneficial effect from medication, and there is something called a remission, like a complete remission of symptoms. So we need to be clear about these areas. There are various studies kind of on psychopharmacology, on borderline personality. A Cochrane review on pharmacotherapy concluded that differences between the drugs were not statistically significant, and the effect size of all these remained at best modest. But this is one area. But if you really look at the symptom dimensions, they showed improvement with psychopharmacological treatment. So there are some hope, but we cannot really entirely depend on medication. I think that's a take-home message I would probably like to highlight. So very important that we need to standardize the psychiatric medication. It is always better to explain to the patient about what kind of medication that we are going to use and what is the purpose of that medication, and how long that we are going to really use, and then how we are going to continue or whatever. So we need to have a realistic plan or realistic goals about the benefits of medication that we need to convey to the patient, and the emphasis on the value of patient collaboration. So it's up to the patient to take a lot of decisions regarding this. So we need to constantly have discussion with the patient, and we'll have to be very, very systematic in choosing the medication, and always stick to rational prescribing, and as much as possible avoid polypharmacy. Lot of evidences for this pharmacotherapy area. Combining antidepressants has not been shown to increase the mood symptom remission. And we all know that the more drugs that you use, the more side effect burden comes up. And it is also very well known that these individuals are extremely sensitive to side effects. So they are likely to report a lot of side effects, and then likely to discontinue the poor compliance or irregular medications, and all that can be there. So we need to be clear about that. And it is very, very important that the pharmacology has no role for certain core symptoms of borderline personality, such as this constant avoidance of this abandonment fear, the abandonment fear that whether the person would leave me and go. This is considered to be one of the core feature of borderline personality, and the chronic feelings of emptiness, the identity disturbance, who am I, and then what kind of person I am, and then these are all the ones to be dealt non-pharmacologically, and then the dissociation. So all this kind of cannot be the target symptoms from a pharmacological point of view. So this is a small slide which shows what are all the drugs which have been used and what kind of target domains. If you really look at the antipsychotics, usually the targets the anger issues and the cognitive aspects of borderline symptomatology, such as perceptual symptoms, the person with the quasi-psychotic episodes and all that. You can look at various antipsychotics have been tried, and this is very common in clinical practice. A lot of time that we see borderline personality disorder, people are put on mood stabilizers. So kind of whether it is given for comorbid bipolar, or there was a diagnostic doubt, or it is to control the impulsivity. So that's the most important target symptoms for the use of anticonvulsant mood stabilizers. So especially the impulsive and behavioral discontrol. If you really look at the effect size is very large for anticonvulsants for this particular area. And you can also use it for extreme anger issues, anxiety and depressed mood. And antidepressants are also used mostly for anxiety and depressed mood. But if you really look at the effect size for that, they are usually small. And you can look at that almost all the drugs have been tried in various trials. Very important about management of borderline personality comes as principles of risk management. So the basic baseline risk level of borderline personality remains chronically and consistently elevated, and it can worsen acutely and at times of crisis. So each crisis does become an opportunity for learning, and some markers suggesting the escalation of dangerousness include any recent negative life events, any objective or perceivable abandonments. So when they think that like they are going to have a major breakdown in their relationship and all that, so they can present with very high risk during those times, and acute changes in mental state or sudden change in their substance use status. So it is better to have a risk profile. Both the clinicians as well as the patient, actually, they have a combined discussion, and then like they need to really identify and then like, okay, try to have a risk profile for that particular individual, which is very, very helpful. And that profile should include, there is something called non-lethal self-harm behavior and true suicidal ideation, which is very important. And any change of person's personal set of usual self-harm profile emerges. So usually he does one kind of self-harm, but currently that he has changed to some other kind of self-harm behavior. So that needs to come into the profile of that patient. And what kind of threshold that we need. So when do you really want to come for help, and then when you can manage on your own. So that kind of discussion is very important with patients, so that because because they may have this self-harming behavior so frequently, and then like utilization of service. See, they cannot come to a psychiatrist for each and everything. So we need to have a threshold for that. So, okay, till this time that I can manage on my own, but if it goes beyond that, and then I would come for help. So remain pragmatic and recognize your own limits in risk management. Because this is very important, because all of us work at a very, very different setup. So some of us work independently in a private setup, and then some of us have a psychiatric nursing home setup. Some of us have a teaching institute with complete backup of psychologists and social workers. So everyone should recognize our own limitations in terms of how much or how far that we can help these individuals. So that's very, very important. So it becomes very important for the particular psychiatrist. So some can have a team, and then some can manage on their own. Okay, now I'll move on to the quiz. It's kind of like, okay, so the quiz number 3. Which of the following best differentiate borderline personality from bipolar disorder? The answer is B. Mood shifts are short-lived and reactive to stress. So that's probably the best answer I can think of. Quiz number 4. Which of the following statement is false? So no medication is FDA approved specifically for borderline personality disorder. Atypical antipsychotics may help with impulsivity and transient psychotic symptoms. SSRIs are the first line of treatment for borderline personality disorder. Mood stabilizers are beneficial for affective instability. Here you are supposed to find which is false. I think this also to me looks fairly straightforward and easy quiz. Anyway, we'll see the answer a bit later. Few seconds. I'll keep this. I'll move on to this psychotherapy in borderline personality. There are several psychotherapies that have been shown efficacy in one or more randomized control trials. These treatments include based on cognitive behavior theories, something like very commonly that like what we call it as DBT, dialectical behavior therapy, and schema-focused psychotherapy, and psychodynamic theories. The recent advances in terms of mentalization-based therapy and transference-focused psychotherapy. And RCTs and meta-analysis suggest that patients treated with one of these treatments are better than those on treatment as usual, but no difference between any active specialty treatment. So these therapies are beneficial, but not much of difference between one to another. So the clinicians are justified in using any of this efficacious treatment and might consider developing expertise in more than one approach. So DBT is very common. We all know about it. And DBT is an integrative model that blends elements from traditional CBT with acceptance-based practice drawn from Zen and humanistic approaches. And it's originally developed within the context of borderline personality, but has evolved as a treatment of multi-disordered complex client populations. Multiple RCTs have examined the effectiveness of DBT. The findings indicate that dialectical behavior therapy is consistently superior in reducing the self-harm behavior and suicidal behavior, healthcare utilization, and improving the treatment retention. A brief word about mentalization-based therapy. So this is basically the MBT views the symptoms of BPD as resulting from distortion or reduction in social cognitive capacity called mentalizing. So that is the core principle behind this mentalization-based therapy. And it is usually the mentalizing is defined as the ability to understand the actions of oneself and others in terms of mental state, including both thoughts and feelings. So trying to understand my own emotions, and then I also try to understand how the other person feels. So that's called a mentalization. So the core goal of MBT is to improve the client's capacity to mentalize by helping them to regain mentalizing when it is lost. So when a person feels that like he's losing that kind of like, okay, he's not able to really analyze his own self emotions and all that. So try to regain it and maintain it when it is present and increase the mentalizing stance in situations where it might be lost. This is a very common, a general principle called a good psychiatric management. So this was basically developed by Gunderson. He kind of like came out with this concept. This is basically used as a control group for RCTs in borderline personality disorder. So this has some basic principles. So it says that like the clients are viewed and treated as competent adults. Therapists are encouraged to be flexible, and attention is accorded to client's role functioning. So it has three basic modes of intervention, including the case management, psychodynamic psychotherapy, individual psychotherapy, and symptom targeted medication management. So it's something like, it looks like a very general, common sense kind of approach to these individuals with borderline personality. This is an important point that like I thought I'll just highlight on this, that the counter transference issues. So historically, the borderline personality disorder is viewed as very difficult to treat, and the patients are noted to have they don't adhere to treatment recommendations. So in fact, many times like okay, we see in our clinical practice, they present in crisis. After 1 or 2 sessions, they may not turn up. So they drop out from the treatment, and then they uses the services in a very chaotic manner. So they come and then like they come for some kind of direct suggestions and advices. Then they kind of like drop out again from the treatment. Many clinicians are intimidated by the prospect of treating these borderline patients, and they are many times they are very pessimistic about the outcome. Therapists treating borderline personality have displayed a high level of burnout. So if kind of like if they are really seeing borderline personality in large numbers, and then like okay, they always feel that like okay, they are having a lot of burnout. And recognizing counter transference is very important, and it also has got a lot of diagnostic utility because this helps us to understand the emotions and then like working with the patient. So it is also very important to know that like in personality disorder, the counter-transferent responses occur in a predictable pattern, and they are useful in understanding the patient's pattern of relating to others. The answer for quiz number 4, which of the following statement is false? Obviously, the SSRIs are the first line of treatment for BPD. So there is no drug for, no specific drug you can call is a drug of choice for borderline personality disorder. So you need to really choose the drugs as per the need of the individual with a clear plans. This is my last quiz. Which of the following distinguishes DBT compared to traditional CBT? Focus on cognitive distortion, behavioral activation strategies, emphasis on emotional regulation and mindfulness, exposure therapy. This is quiz number 5. So if I have to summarize the principles of management, this is what it is. The treatment has a clear framework. The workers jointly agreed on goals and targets. The therapist is active. The emotions are at the center of work. The quality of relationship is constantly monitored. So this is how that we kind of view borderline personality disorder from a management point of view. So we need to really understand our own limitations and to have a very clear plan. And the therapists usually play an active role and always constantly monitor on the emotion. Couple of slides on long-term outcome. The long-term follow-up studies indicate most patients experience a remission of the disorder, and sometimes they can have a recovery also. If you really look at the 3 clusters of personality disorders, typically the cluster B personality is considered to be what we call it as an immature personality. That means you can expect some kind of change in them in their 4th or 5th decade. Whereas the cluster A and cluster B personality disorders tend to persist even during the old age. So you would see an ancastic personality disorder person still does all that meticulousness even in his 7th decade or 8th decade, but person with a borderline personality loses his energy over a period of time, and then by 5th or 6th decade, a lot of the symptoms can kind of come down in severity. So some of the predictors of good outcome include the factors related to personal capacity and competence, good psychosocial support, and levels of normal personality traits. Similarly, predictors of poor outcome includes a greater severity and chronicity of illness, higher degrees of comorbidity, and history of childhood adversities. About 30% of patients have an excellent outcome, and about 40% of patients never achieve remission. Acute symptoms such as self-mutilation remit more rapidly than temperamental symptoms, that is chronic depressed affect, and never achieving recovery from BPD is associated with occasional impairment and physical health problems. So that's why it's very important to really look at the assessment of the impairment and the quality of life. And the factors related to competence or resilience are consistently prognostic and most amenable to change. So how much they are resilient. So that probably predicts the long-term outcome. The answer for the quiz number 5, which of the following distinguishes DBT compared to CBT? The answer is C, emphasis on emotional regulation and mindfulness. Just by conclusion, borderline personality disorder is a common, serious, and clinically heterogeneous disorder, and a lot of attention to be given for assessment of psychiatric comorbidities. And the assessment should promote the understanding of patients' emotional, behavioral, and relational and occupational needs. And the management with the existing mental health framework. So it varies from individual to individual, depends on what kind of setup that they have. This is both confusing as well as challenging. So we need to accept or evaluate our own limitations in terms of managing these individuals. And utilization of standard psychiatric management principles such as sound diagnostics. So be clear about the diagnosis and use the pharmacotherapy in a rational manner and give a lot of importance to risk assessment and management. And so this can contribute to observable stabilization and improvement. So with this, I finish my presentation. And if anybody has got any questions or any clarifications, we can do that. Thank you.
Thank you, sir. Thank you so much for the elaborate presentation, sir. We are all enlightened by the presentation, sir. Now I request Dr. Roop Sidana, sir, to give his comments on the presentation, sir.
Thank you. Indeed, and I'm really impressed by the way he has covered the assessment and the management with evidence-based figures. And my only comment as a practitioner of last 4 decades is I find this is the most difficult diagnosis to make, and more difficult to treat the patient with bipolar disorder, especially if you have a standalone practice, if you have a limited team, because it is very taxing for the practitioner to manage a patient with bipolar, with borderline personality disorder, because if you give the liberty to contact you on phone, these are the people who will keep on troubling you, and these are the people who will give you a kind of nightmare that if he or she does a self-harm or commits suicide, I'm going to have problems. And so I think the diagnosis has to be, once we suspect, we need to follow up and evaluate accordingly. And once we diagnose, we need to check out the plan after explaining to the individual. And lots of management depends upon the therapist's own personality and own individual views about. I have seen that many of the even mental health professionals have varying attitudes towards borderline personality disorder patients, and they wave between uh, either changing the diagnosis or uh, feeling that maybe it is a malingering or some secondary gains are there which the patient is asking for. And the transference and counter transference both are common with borderline personality disorder patients. If one is doing therapy, especially the psychotherapy with psychodynamic principles or even with cognitive behavior therapy, there are chances of having both transference as well as counter transference, which need to be managed. And the pharmacological management is symptom based, phenomenologically based, and depends upon the type of symptomatology that you have. And you need to evaluate frequently whether you are giving mood stabilizer, whether you are giving antidepressant or any other molecule. You need to uh, evaluate again and again whether the patient really needs the same medication or we need to stop or change it. That's my view of how I look at the borderline personality disorder in practice. But indeed, I must congratulate and compliment Professor I. Anand for a very wonderful presentation on borderline personality disorder. Thank you.
Thank you, sir. Thank you for your words.
Sir, we have few questions in the chat box.
Yes.
You can take them, sir. There is a question from Dr. Prachi saying that, sir, excellent presentation. Appreciate the inclusion of importance of psychotherapies for the management. How would you differentiate BPD with cyclothymia in practice?
I think it's a very nice question and then extremely a difficult answer also. So kind of like, okay, so that's a very nice question. See, not even cyclothymia, like, okay, even if you really look at the borderline as a bipolar type 2, so this can have a lot of similarities or overlap. But my understanding, like, okay, cyclothymia, it's more to do only with the fluctuations in mood, not to a hypomanic high, at the same time, not to a qualifying feature of a depression. So it's primarily a mood disorder. But in borderline personality, the affective instability is just one of the symptom of borderline personality. But much more core features are the other features that like the impulsivity and the fear of abandonment and then the chronic feelings of emptiness. So the cyclothymia people kind of like, okay, presents primarily with the shift in their mood, but without any other features. But in borderline personality, the mood swings are there, but that is one of the symptom of borderline. But they also have other things which are identity issues and then the chronic feelings of emptiness. So the other features, I think, would contribute to think of more in terms of a borderline personality.
Yes. Thank you, sir. We have one more question from Dr. Sadhana. She is asking, like, sir, in BPAD during the inter-episodic period, the patient will have a stable sense of self, which differentiate it from borderline personality. I think she is getting to come to the point saying, like, how will we differentiate the inter-episodic period in bipolar disorder and borderline personalities?
See, I think a bipolar disorder, we by and large, like, okay, we expect a complete remission of symptoms in bipolar disorder. So when they are in remission, they are completely remitted. I'm not talking about a small percentage of people who have a residual symptoms, but to a large extent, the bipolar disorder, when they are remitted, they are usually to pre-morbid level of functioning. But in borderline personality, we probably talk about continues to have some or the other issues apart from the mood symptoms. They have this impulsivity and then the other core features. So that way that like we will be able to differentiate. So the borderline personality disorder person, when we talk about remission, they are relatively better functioning, but they continue to have their chronic feelings of emptiness, and then the self-harming coping. The self-harming, I would say that like that's a way that like they cope up with their stressors. So that continue to hurt them, and then so that is how that like okay you differentiate these two things.
Yes, sir. Thank you, sir. We'll conclude with the last question, sir. Dr. Bharati has asked, how do we differentiate an adult ADHD from borderline personality disorder with impairment in occupation?
Yeah,
Adult
again, yeah. So see, I think each of the other diagnoses, like, okay, if you really take away that core symptom, say, for example, ADHD, if you take away that the core hyperactivity or impulsivity, that attention deficit hyperactivity part, otherwise, the ADHD people, unless they have a comorbid depression, so we are not really talking about any kind of mood issues with them, and their impairment is more likely to center around the poor concentration, and then inability to stick on to a particular task for an extended period of time. So that's how the ADHD, the adult ADHD is differentiated compared to borderline personality. So here, the borderline personality comes everywhere. So because the symptoms of borderline personality kind of like mimics most of these things, but if you can carefully differentiate ADHD or mood disorder or whatever, like, okay, so if you look at the core symptoms, only that symptoms are there. But here, borderline personality, we are also kind of like, okay, dealing with other symptoms of personality. So we'll have to really see from that point of view.
Thank you, sir. Thank you again, sir. Sir, one personal question from my side, sir. Regarding pharmacological management of borderline personality disorders, recently endoxifen is being promoted for impulsivity, even also for bipolar disorders, right, sir? Any personal experience from your side, sir?
No, I have not used endoxifen at all. But what I'm saying is that, like, I think the pharmacotherapy guideline is very clear in borderline personality disorder. You decide to give any drug, but be clear about what are you giving it for, how long that you are going to give it, and then what are all your target symptoms, and then discuss with patient about why do you want to use this. I think this is a basic principle of any pharmacotherapy in borderline personality. See, there can be a lot of drugs. They can claim that like this can happen, this can happen. But I don't think that like any drug can change the core borderline personality structure. So we are basically talking about a symptomatic treatment. So we need to have a clear clarity between the patient and ourselves about why are we using it and what are we going to do with this medication. And if it is not really beneficial, we should be bold enough to withdraw the drug also.
Thank you, sir. Thank you for patiently answering all the questions, sir. Now I request our course director, Dr. C. Paniselvan, sir, to deliver his concluding remarks for the day. Sir, kindly unmute yourself, sir. Paniselvan, sir, kindly unmute.
Thank you, Dr. Anand, for your wonderful and very informative presentations. And more participants stayed till the end of the presentation. I thank Dr. Rup Sidana, sir, for sparing his valuable time to chair this session. I thank my colleague, Dr. Aswad Babu, and all the participants for active listening and participating in the discussion. The YouTube link for the previous section and current session will be available in the YouTube. So please contact Eastwest Pharma for more details. Special thanks to the sponsor Eastwest Pharma. I conclude the session with the Eastwest Pharma water thanks. Thank you all. Thank you for your attention.
Thank you, Doctor. First of all, I thank to our Dr. Anand sir has given, our speaker has given a lucid presentation and it benefited for all PGs. And we are extending our from Eastwest Pharma our gratitude to our chairperson Dr. Roop Siddhana from who are spending his on his busy schedule, who's spending time for the program for the benefit of the PGs, and also he has given his point of view also for the benefit of in the exam point of view. And Eastwest Pharma extend our gratitude to the course director Dr. Selvan sir was conducting wonderful session for the past 2.5 years continuously, and also thanks for moderating Dr. Ashwat Babu sir and Madam to moderate the program wonderfully. And this winners list will be published in the next program, and you will all the winners will be received with the rewards of certificate as well as gift vouchers directly by our field force. For any link of this program of our Eastwest Pharma of this Evolve program, kindly contact our field force from the Eastwest Pharma. And thank you, wonderful opportunity for all, and have a good day to all.
Thank you.